Hello, I'm Petros Grivas. I'm a medical oncologist at Seattle Cancer Care Alliance, and I would like to thank the organizing committee, thank Professor Dr. Crawford and Professor Dr. Theodorescu for their very honoring invitation for this very interesting controversy or debate regarding the use of systemic therapy neoadjuvantly in localized resectable muscle-invasive bladder cancer. I want to point out that I'm really a believer of the level 1 evidence of cisplatin-based neoadjuvant chemotherapy, the counterpoint that my colleague, mentor, and friend Dr. Dreiser will present. But I would like to present to you my personal vision about the future, how I predict or estimate the future will look like with the use of checkpoint inhibitors in the neoadjuvant setting. However, as of now, the role of immune checkpoint inhibitors in the neoadjuvant or adjuvant setting of muscle-invasive bladder cancer remains investigational and is being tested in clinical trials. On the contrary, neoadjuvant cisplatin-based chemotherapy is the standard of care as shown in meta-analysis and phase 3 trials. These are my disclosures. There is certainly a strong foundation supporting the notion and concept of neoadjuvant immunotherapy across tumor types. And specifically, if you think about data in lung cancer, melanoma, brain tumors, and colon cancer, there is very, very promising signal from data sets that definitely highlight the idea and the rationale why neoadjuvant immunotherapy might work. And this is very compelling if you think that when you have the primary tumor in place, you have an intact lymphatic system that can facilitate trafficking of T cells of the immune system, and you have the primary tumor in place, so the immunotherapy can work very well conceptually in this setting, and you may enhance T cell responses that can translate to clinical responses and pathological responses in this neoadjuvant setting. Obviously, muscle-invasive bladder cancer is really the optimal setting and disease type to test the hypothesis of neoadjuvant immunotherapy. If you think about it, about half of the patients with locally advanced disease, extravesical disease or node-positive disease at cystectomy, they have limited long-term survival. And despite the level 1 evidence with cisplatin-based combination chemotherapy, only a small proportion of patients, sometimes less than 20% of patients, receive that neoadjuvant cisplatin-based chemotherapy. There's certainly an underutilization because of fear of toxicity and because of the fact that about half of the patients, as you see in the right part of the slide, are not fit enough to receive cisplatin-based chemotherapy. And there is definitely an urgent unmet need to develop systemic therapies like immunotherapy-based strategies in cisplatin-unfit patients, and to build upon the benefit of cisplatin-based chemotherapy in cisplatin-fit patients. Keep in mind that about half of the patients who receive neoadjuvant cisplatin-based chemotherapy and have muscle-invasive disease at cystectomy, they have high risk of recurrence and ultimately death. So definitely there is a need to improve outcomes. The prototype clinical trial in the neoadjuvant setting with immunotherapy in muscle-invasive bladder cancer was by Dr. Necki and colleagues, the PURE-01 trial that taught us a few lessons. Number one, pembrolizumab as single agent checkpoint inhibitor was active with very promising efficacy signal and the pathologic T0 rate of 42% and pathologic downstaging to non-muscle-invasive disease in 54%, so more than half of the patient had T1 or less in pathologic stage. So definitely important promising signal in a phase 2 trial with single agent anti-PD-1 therapy. Moreover, Dr. Necki and colleagues showed that they could potentially show activity in variant histologies and potentially expand the pool of patients that might benefit from neoadjuvant systemic therapy. As we all know, the role of cisplatin-based chemotherapy is questionable in patients with pure or predominant non-urothelial histology. Having said that, there's data from the SWOG trial, SWOG 8710, that rendered the conventional classic MVAC standard of care that showed a significant benefit in urothelial cancer that exhibits squamous cell and glandular features. So the presence of those features should not discourage the use of neoadjuvant cisplatin-based chemotherapy based on the SWOG 8710 trial. However, there's an opportunity to improve outcomes in patients with variant histologies, and keep that in mind for my next slide. Dr. Nake and colleagues also showed that they could test the hypothesis of novel imaging with multiparametric MRI, and there was an association between complete response in this MRI model with pathologic response, and the area under the curve was 0.75, which definitely set the stage to test this hypothesis in prospective phase 3 trials, and definitely this data need further validation. Pembrolizumab was safe, and this is an important point regarding the safety of this checkpoint inhibitor in the neoadjuvant setting. Talking about variant histology, I want to point out we have an important pilot clinical trial at the University of Washington and Seattle Cancer Care Alliance and Fred Hutch in my institutions. We are testing the combination of accelerator dose-dense MVAC with growth factor support plus pembrolizumab chemo-IO combination in the neoadjuvant setting of patients with variant histology, meaning predominant or pure non-urothelial bladder cancer. And we're going to evaluate this prospectively, and hopefully we can accrue very well with the support of colleagues. The point I made before is that we can potentially utilize novel imaging modalities like parametric MRI. And again, there is a need to prospectively validate the hypothesis generated by the PURO-1 trial that pathologic downstaging on MRI or pathologic response, pathologic complete response or downstaging on pathology could potentially be predicted by radiologic complete response. And that's something that we have to, again, evaluate further in prospective trials, but interesting hypothesis to look at. There is plenty of data suggesting that the adjuvant immunotherapy appears safe and does not increase the risk of complications with radical cystectomy and pelvic lymph node dissection. And in the PURE-01 trial, the high-grade complications with pembrolizumab neoadjuvant therapy was about in 1/3 of patients. Again, if you think about neoadjuvant cisplatin-based chemotherapy, I think neoadjuvant immunotherapy appears feasible and probably relatively safe in the majority of patients. This slide shows a summary of different phase 2 trials that generate very promising signal and make the idea of phase 3 trials testing immunotherapy very compelling. The PURO-1, Abacus, Nabucco, the Hoosier Oncology Group, BLAST, and Neutrino trials, as well as other smaller trials, have shown a pathologic complete response rate with neoadjuvant immunotherapy-based strategies that vary from 31 to 46%. And if you think about pathologic downstaging to non-muscle invasive disease, this is between 50 and 66%. I think this pathologic complete response and partial response rates are promising, are not practice changing yet, as I said before, but definitely support the ongoing large, important phase 3 perioperative trials with immunotherapy. And there is certainly an opportunity to develop biomarkers as shown in the last row of this slide, and the biomarkers could potentially be promising. Speaking about biomarkers, the Abacus trial and the PURO-1 trial evaluated biomarkers as well as the other immunotherapy trials. As I mentioned, the Abacus trial utilized atezolizumab anti-PD-L1 single agent and showed a pathologic T0 rate of 31%, about 1/3 of the patients, which seems in line of what you get with neoadjuvant cisplatin-based combination chemotherapy and with less toxicity. So definitely a very promising opportunity here with neoadjuvant immunotherapy, within 1 year recurrence-free survival approaching 80%. And as I mentioned, there is an opportunity of establishing, identifying, and then validating biomarkers in this neoadjuvant setting in tumor tissue, as well as blood and urine. In this particular trial, there was no significant association between TMB and PD-L1 and the pathologic response to neoadjuvant immunotherapy. However, TMB, tumor mutational burden, and PD-L1 were associated with higher response to neoadjuvant pembrolizumab. So different trials may have different results in terms of biomarkers, but definitely the opportunity of biomarker validation exists. Talking about biomarkers, there's some interesting data suggesting that neoadjuvant immunotherapy might benefit significantly a proportion of patients, and gene expression profiling or DNA-based sequencing can potentially help in the identification of those patients. As you see in that slide, there is a hypothesis that patients with higher genomic instability could potentially benefit more from neoadjuvant chemotherapy. And contrary to the hypothesis we had, patients with tumors with non-basal squamous subtype may benefit more from neoadjuvant chemotherapy obviously there is need for prospective validation in those molecular biomarkers, and they are not ready for prime time. Similarly, Dr. Naik and colleagues saw data with gene signatures, and you see here gene signature regarding interferon alpha response, interferon gamma response, inflammatory response, and this immune 190 signature. And as you see in the right part of the slide, this immune 190 signature could potentially be associated with higher benefit from neoadjuvant immunotherapy and less benefit with neoadjuvant chemotherapy, again, based on the quartiles. But I would like to say that these very promising data are not ready for prime time, but definitely set the stage for prospective validation in phase 3 trials. And here is just a prediction of potential future landscape. We might get to the point, we're not there yet, but in the future upon validation, we may tease out, select, dissect different biology of disease. And based on the biology, we might be able to allocate patients to different neoadjuvant treatment modalities that may fit the immunology and biology of disease. And based on that, if we can have a trial treatment allocation that could prospectively validate this hypothesis. And ultimately, the goal is to have optimal and personalized patient selection. There is a plethora of trials looking at combinations of immunotherapy, and also the idea of bladder preservation is very compelling. Think about immunotherapy-based strategies with chemotherapy and or radiation therapy. And here I would like to pull the plug for this phase 3 atezolizumab plus chemoradiation trial after maximum TURBT that aims to evaluate bladder intact disease-free survival, bladder intact disease survival in patients who have localized bladder cancer. And the question in this trial is whether the immune checkpoint inhibition can increase the benefit with chemoradiation as a bladder preservation strategy. There is a similar phase 3 trial with pembrolizumab, and I think those trials are interesting to watch to see what happens down the road in terms of bladder preservation. Moreover, there is a plethora of phase 3 trials with immunotherapy, and this definitely is very important. We definitely need to accrue in those trials. I put 5 of them, phase 3 trials in the neoadjuvant and or adjuvant setting, and those might define the role of immunotherapy down the road. This is one of those trials. Dr. Sompavde has presented this schema with the ENERGIZE trial, looking at chemotherapy as neoadjuvant approach versus chemotherapy plus nivolumab versus chemotherapy plus nivolumab plus dronostat, which is another inhibitor of the IDO1 pathway, and this can potentially synergize with immunotherapy. So very interesting concept to look at. In the purely adjuvant setting, we have some mixed messages. We have 3 big trials: INVIGO010 with atezo, Ambassador, which is ongoing with pembrolizumab versus observation, and the CheckMate 274 trial. The first trial, the INVIGO010, showed that atezolizumab did not prolong disease-free survival in the purely adjuvant setting. That may raise the hypothesis that you may need a neoadjuvant component in this immunotherapy approach. But definitely this was a trial that did not show benefit with a purely adjuvant checkpoint inhibitor versus observation in patients with muscle-invasive bladder cancer with adjuvant atezo versus observation. Interestingly, the CheckMate 274 trial showed that adjuvant nivolumab appears to prolong disease-free survival in all comers and also in the subset of patients with PD-L1 positive tumors. We have not seen the data yet, but the press release showed that this trial met the primary endpoint. I have not changed my practice yet, but we have to see how the data look like in this purely adjuvant immunotherapy trial. To conclude my thoughts, pathological complete response rate with immunotherapy, there are single agent or tablet immunotherapy is very promising. The pathological complete response rates are very promising, and this promising signal in phase 2 trials raise the hypothesis and sets the foundation and support the rationale for ongoing phase 3 trials that I showed you before with neoadjuvant immunotherapy. And pathological complete response rate and event-free survival are the primary endpoints of those phase 3 trials. Specifically in cisplatin-unfit patients, they can definitely try to meet this unmet need in those patients. Cisplatin-based combination chemotherapy plus immunotherapy is being tested as an approach in cisplatin-fit patients. And again, this is a very promising and realistic expectation. If those trials achieve the primary endpoints, they could potentially change practice in the future. We need to confirm on a patient point level whether pathological complete response and event-free survival correlate with overall survival, and we definitely need to develop and validate prospectively biomarkers to enable a more personalized approach and better patient selection for the right therapy at the right time. And we have to align biomarker validation across phase 3 trials. There is definitely need for multi-specialty clinics and tumor boards with urology, medical oncology, radiation oncology, and other specialties. And definitely there is a need for incorporation of rehabilitation programs, safety endpoints, patient-reported outcomes, quality of life, imaging analysis, and systematic, comprehensive, cost-effectiveness analysis that can inform discussion about clinical practice down the road. Thank you so much for the attention and looking forward to further discussions and collaborations in this setting. Thank you.